Welcome everyone to the Sexual Differentiation Clinic. Service while in the uterus, post-uterus, and life in a relationship. Providing the following services: pediatric endocrinology, pediatric urology, clinical genetics, psychology, social work, and legal advice. Special considerations in the consultation. Let's start with the definition. What is a sexual differentiation disorder? In most occasions, it can be defined when a phenotypic sex of the patient does not properly relate to its gonadal, hormonal, or genetical sex. So what's the importance of these consultations? Patients with these diagnoses, as well as the biological or adopted family belong to a special regime which deserves our respect in order to receive optimal, adequate, timely, and persistent information. The approach of these patients should be interdisciplinary, hand in hand with the service of pediatric endocrinology, pediatric urology, psychology, social work, genetics, and lawyers, with the training in such situation. Therefore, they require access to entities of fourth level of care, since we have found that patients referred from other institutions are referred to the clinical of sexual differentiation disorders without diagnostics, misdiagnosed, or with inadequate treatment. The clinical history of these patients should be complete, adequate, and specialized, based on information provided by biological or adopted parents of the child, which allow us to know the situation to which the patients had been subject prior to the specialized consultation, establish how well informed the minor of his or her biological or adoptive relatives are about their pathology, their coping capacity, the diagnosis and treatment they have been given so far, so as to allow us to determine the starting point and later follow-up integral sustainability of the patient's welfare according to the pro-infant's rule or superior interest of the child. It is necessary to differentiate 4 different scenarios, each respecting of a different age. The first scenario, from the prenatal stage to the newborn and under 5-year-old. 2. From 5 years of age to 12 years of age. Third scenario, from 12 to 16 years of age. And the fourth, from 16 years of age until he or she is of legal age. The mental condition of the patient must be kept in mind to determine who determines the legal capacity of the legal right to health and life in a relationship. So what are the objectives? To instruct the patient with a specialized interdisciplinary approach that is easily accessible, which allows the child and his or her biological or adopted family to know the diagnosis of their pathology, and according to the patient will receive the advice regarding pharmacological treatment, surgical treatment, appropriate time for the accomplishment of this, psychological preparation, counseling, and genetic studies, as well as the permanent monitoring done by the clinic. To sensitize the medical insurance companies or prepaid medicine on the sexual differentiation disorder, to make them understand the specialized care demanded by the patient and the importance of assigning the authorizations on multidisciplinary assessment as quick as possible in order to avoid delays in care and disruptions in the continuity of the patient's follow-ups. To train and sensitize the patients and his family, they must be discreet and assertive, handling the information of their sexual differentiation disorder in order to preserve the integrity and intimacy of the child with the disorder, and this way to avoid the abuse to which they can become subject to. Encourage the use of tools that facilitate the acceptance, adaptation, and understanding of the sexual differentiation disorder through medical and legal advice in order to avoid major damages, and if necessary, referral to psychological or psychiatric support. So what's the clinical histories approach? The medical history should include 1. A companion, a person who you go to the consultation with, either their biological parents, with their full names and occupation to evaluate expositions. 2. Birthplace, to evaluate risk areas, either urban or rural. 3. Whether or not they are in a degree of consanguinity. 4. Reason of consultation. 5. Background, including parental exposure, prenatal exposure, medication, hospital or home delivered. 6. Knowledge of any diagnosis at the time of diagnosis and information about this. 7. Treatments previously received, including dose and duration. 8. Prior evaluations by specialists such as pediatric endocrinologists, clinical genetics, pediatric urology, psychology, and social work. So what are some of the key points for the assessment of the patients at the time of inquiry to the clinic consultation? In the case of follow-ups, we need to review the previous medical history with the specialist before calling the patient to avoid non-conformities by the minor and his relative. When calling the patient, it must be announced by the two surnames and not by the names, in order to generate emotional distress to the child and his family, since the patient may be developing in the opposite gender to the registered name. The child must be accompanied by one or both biological parents, and information will be given only to them as legal guardians, in order to preserve the child's right to privacy. In addition, the name of said parent should be recorded in the medical record. The legal counsel may be presented during the consultation in the company of a specialist, except in situations in which the patient and or her family request total privacy. The parents can leave the consultation so that the minor can express their concerns to the specialist once the genital examination has been performed, always in the company of one of them. The legal counsel shall not disclose any personal concepts to the patient or his or her family regarding their sexual differentiation disorder, even in cases where they are the ones who inquire about this. The health personnel who work in the clinic and maintain contact with the patient should remain undisturbed during the consultation. The only person authorized to give information on the current state of the sexual differentiation disorder, treatment, management, and follow-up will be the specialist of each service that intervenes for the interdisciplinary approach of the minor. Once the patient has entered the room, the door must be secured to avoid interruptions of external persons, with the aim of promoting privacy and respecting the right of the integrity and intimacy of the child during the consultation. At each consultation, there will be a supply of gowns, which will be given to the child or relative so that it is placed with the opening forward. Once he or she is undressed, with the help of the mother, if it's required, to offer a greater privacy. The mother will be responsible for removing the child's underwear prior to the review by the specialist, and if the child does not agree with the to be reviewed at that time, the review will be postponed for a subsequent consultation where the child is more comfortable or confident enough to do it by himself. This will be recorded in the child's medical record. The specialist will have gloves throughout the whole consultation. This review must be done exclusively by the specialist. If the legal advisor needs to know about the exam, information will be only given if the parents authorize it. In case it is decided to present the case of the child in the meeting of sexual differentiation disorders, we will request the consent of the parents for the taking of photos in order to be presented before the different specialists and thus define decision-making and avoid to infringe the integrity of the patient. Parental consent must be recorded in the child's medical record. Similarly, information should be handled with utmost prudence and privacy, using initials of the patient's name so as not to violate the integrity of the patient. The information of cases handled with the other specialists is completely private and must be protected by habeas data in compliance with Law 1581 and the Decree 1377 of 2013 on the treatment of the personal data of minors and adolescents, and in agreement with the constitutional and legal duty to protect the fundamental right of the health of the minor or adolescent. In addition, it is governed by the guidelines of the treatment of personal data Clinic of Sexual Differentiation Disorder in Bogota, July 22, 2016. The specialist will issue the concept and therapeutic options available on a case-by-case basis, through complete information addressed to the biological or adoptive parent. And an informed, qualified, and persistent consent will be obtained from the therapeutic decision taken by the sexual differentiation disorder clinic or in conjunction with a group of sexual differentiation disorders, patients, and family. Understanding as informed consent that information given by the medical staff with the objective of communicating to the biological parents all the details information of the risk, knowledge of alternative therapies and possibilities and implications of not having any intervention. Qualified, it should also include exposing the possibilities of intervention, limit, and risk of the procedures through detailed and concise information that allow the patient and family to make the most appropriate decision. Persistent, a condition that requires parents to question the diagnosis of the diagnosis in a distant and repetitive way on multiple occasions in order to ensure clarity regarding the information given to the parents, allowing them to make decisions about intervention to perform the minor. The physician should strike a balance between the persistence in the time of consent and the promptness with which the procedure is required. Now, with respect to the pre-personal procedures, or the one that is about Now let's continue with respect to the prenatal procedures, or the ones that are about to be born. It will be suggested to assign names that latter service for both genders in order to avoid assignments before finishing the appropriate study. Examples: Lila, Michael, Kenny, Lenny, Ariel, Darcy, Britt, Andrew, Manny, and Danny. Avoid using terms that identify the child in one or another gender and learn to use words such as creature, patient, minor, or infant. The use of garments of neutral colors such as white, yellow, green, multiple colors as not to generate connotations of a specific gender until finishing the study of the patient. Every patient born alive with a disorder of sexual disorientation disorder should be considered a pediatric emergency and cannot leave the clinic without a diagnosis. Enter the additional box in the newborn baby unit where it appears as an option to place other within the gender classifications, in addition to male and female according to Sentence Tutelage 450A of 2013 of the Honorable Constitutional Court of Colombia. We hope that these recommendations will convey the importance of the knowledge and awareness of the health personnel against disorders of sexual disorientation, which will facilitate an early detection and adequate initial orientation with the objects of obtaining an appropriate diagnosis that allow a timely intervention and an early approach to multidisciplinary and specialized management, including staff within the outside Bogota who will face clinical practice, general practitioners, midwives, residents, obstetricians, and gynecologists, neonatologists, pediatricians, etc.